All right, we have a very full day, and I want to make sure that everyone has all the time to tell us about their registries and the processes and help us kind of think through what registries are for us. So I'm going to go ahead and jump in and get started. Excited, we already have 28 people logged on. Hey, Laura, Lori and Laura. So, welcome everybody. Just want to say welcome and very excited about this presentation today. It's something that we've talked a lot about and that people have been interested in. So I'm so grateful to our speakers who were willing to take this time. We'll say that we did review a lot of presentations that were sent to the CFHA conference, all those that were related to collaborative care. So just part of that process, and really excited. I kept reading them and being like, ooh, I don't think I'm going to be able to go to all the ones I want to see. Thank you to everyone who did contribute and submitted presentations and for the conference, and I am really excited now to go to Austin. So if you haven't made plans to go, we'd love to see you all there, and we will try to kind of put together some SIG related activities so that we can get together and see each other. The other thing, we are hoping to have a kind of an addition to this meeting next month to talk about more of the vendors that kind of provide collaborative care services as kind of a package with care managers and psychiatric consultants. So we are kind of collecting a group. So if you know of someone, a vendor, a person who would like to come and talk in a forum kind of like this, please let us know, because we'd like to hear about that kind of aspect. Laura or Monica, is there anything I left out?
I just put the conference in the chat. So if you haven't registered or want to have more information, take a look. I love going to these conferences. They're a great opportunity to network, learn, and connect. And I don't have anything else.
The only other thing is that we're probably not going to have a meeting in July. It's on July 3rd. And that's usually a week where people are off for the holiday. So we'll take a break in July. All right. So without further ado, I am very excited that we have 4 speakers who are going to talk to us about different registries that either they've developed or that they manage or help to disseminate, and also registries that have been built. And we have Vijay, who's going to be here talking about Akello, which is a open source measurement-based platform. We have Suzy Hunter, who's going to be here from the AIMS Center talking about the AIMS caseload tracker. We have Ben Hillyard here, who's going to be talking about Mirah, which is a registry that they have built. And then we have, fresh off the presses, an additional member. We have Ashley Shattuck, who is from Hartford Healthcare Medical Group, that's going to be talking about their registry that they built in Epic. So I'm really, really excited, and we're going to go in that order. So I will let Vijay go first.
Cool. Thanks, Tisha. By the way, I have some slides. I'll try to be really brief. Is that okay if I can share?
Yes.
Okay, awesome, cool. It's gonna be a lot easier. Give me 1 second. All right, cool. So yeah, I guess some context. How kind of what I'm really doing. I know this is what the conversation that we're in is really around collaborative care, but what I'm trying to do with Akello is make it easy for people to run standardized measurement-based models. That's kind of the overall goal. So do it in a way that it can be done globally. It's not just something that is in the United States, but we can look at this across almost any culture. And then Akello is basically the system, the platform that it helps enables teams to be able to do the work that they need to do. My background, I'm not a clinician. I am very much product and engineering. So I've done most of my career is in building data systems, real-time data systems, stuff like that. I did some robotic stuff before. I did some work at Kaiser. So that was probably more my most significant like enterprise healthcare related work. At Kaiser, if anyone uses Kaiser, their new mobile experience is kind of what I led initially when I was there. So did a lot of their mobile experience for their patients and helping with closing their care gaps, starting with their diabetic population and kind of growing from there. So that was like my healthcare stuff, but really I'm kind of like a engineer product guy here. So what that really means is that I leverage a lot of other folks for clinical knowledge, and I'm kind of just like staying there as kind of like on the engineering side. So Akello is basically, it's an open source platform for measurement-based care models. So at a very, very high level, what that really means is that you can define your measurements, you set up like, you do like, I want to be able to let anyone be able to create custom rules around anything in that clinical workflow. You can define your own clinical workflows and your own type of processes that works for your population and your clinical models. And also there's like hooks into classification models. So like helping you identify which patients make sense to work on, or even potentially identifying, like hook this into an EHR system and help you identify within that population who might be at risk and who might like be worthwhile referring into like a brief intervention or some sort of referral type conversation there. But I think what I realized through my experiences by being at CFHA, which has been amazing, is that, you know, if we can't figure out the billing component, like you can't really run the model. So fundamentally, it's like the first base version of Akello is around how do we help clinics and clinical teams run these models in a way that it's financially sustainable. So a lot of like my initial component and thinking has been around tracking measurements, automating that, doing the billing codes, and kind of generating those reports for the finance teams. And then there's the patient clinical engagement component, but really fundamentally, it's measurements, being able to bill for it, running teams, and then engagement. That's kind of how I'm building up the stack. So roughly, like this is kind of how it looks. It's been, I'm like literally kind of working on this nonstop. So there's like a lot of iterations happening quite a bit. So the way I have a mobile experience now, this is kind of new, but you have your typical registry. What I tell a lot of people is that if you're just looking for, if you just need CoCM, and if you need something like what Ames offers, I refer them to Ames because like Ames just does it out of the box. Akello is really more effective or useful if you need a lot more customized experiences or anything like that, or if you're trying to do something where you're hiring engineering teams and you're really trying to build something custom. What you're seeing here is just a template that I've built for the Akello experience. But with clinics that I'm working with right now, it's very different. So they get a very different experience. This is just an example, which is basically the base case, right? So from the front end side of things, it can look vastly different. So what that means is you can really define and design an experience that makes sense for your population. So if you're doing pediatrics, you might want to have a different experience there versus if you're doing it for senior care or like a different population. So it's very tailored to which population you're serving for. I know this might be a little bit technical, but I just wanted to call it out on how the data processing works, But basically what the way it looks like is that Akello over here has a lot of different types of services that are basically works in modules, very easy to plug in, plug out, based on the needs of the organization. And it hooks into EHRs through like these data subscribers. So I can hook into multiple types of systems. So if you want to be a CoCM service that are providing to multiple health organizations, what's great about this is that you don't need to send your team to different EHR systems to learn how they work. You just work on Akello and the data just syncs across the different data sources. And then I used to, a year and a half ago, I was building a senior facility. So I had an integration with Uber. I was working with Uber Health. And I would basically, with Akello, you can basically create models where if someone is at risk of not showing up to their appointment because they just can't get to the facility, we can send an Uber out there, right? So there's these other types of orchestrations that we can set for depending on what your population is. So that's kind of the back end workflows. That's it. Any questions? Hope that was on time.
Wow, that's great. Yeah, and we're giving everybody about 10 minutes. You started at 7 after, so we've got about 3-4 minutes if anybody has any specific questions about Akello. We are going to leave time at the end. I am not seeing the chat. That is fascinating.
I had a question actually. Sorry, I don't have my video on here, but I work at San Francisco General Hospital, and we use Epic there. And I'm just like wondering how you deal with HIPAA related issues when you're trying to integrate across these different platforms, because obviously we're going to be, if you're tapping into Epic and you're going to be accessing confidential patient information, like how is that managed?
Yeah, it's a great question. I'm an SF too, by the way.
Oh, okay, great.
So there's a protocol Epic uses, which is a global standard. FHIR is kind of the data standard that a lot of EHR systems use, and it's just a way for systems to communicate with each other in a way that like it's easy to be interoperable. And on top of FHIR, there's another protocol that gets built. It's called Smart on FHIR. What Smart on FHIR is it's basically an authentication system that, if you're familiar, like if you go to the different websites that says sign in with Google in a different website, it's like your OAuth thing. Smart on FHIR kind of does that, but does it with EHR systems. And what's really different is that it defines very granular scopes. So what's great about that is that the rules and security policies that are defined in Epic gets applied to Akello, and those permissions are the only way the data comes back and forth between the two systems. So with Smart on FHIR, that's how that would work basically. So that's how it would basically work with the larger systems.
So we don't need to get permission, or do we need to get permissions from any institutional, bodies regarding integration with, like if we wanted to use Akello, like would we need some kind of understanding or shared confidentiality agreement, or how does that work?
That's a great question. But to be honest, I don't know how people buy in healthcare, so I'm kind of new to this. I'm like, I don't know how health systems work in that aspect. But from the Akello side, we'll be signing a business associates agreement. And I think some of the other folks might have a better answer to your question, because they're probably going to be having the same related challenge, or same type of relationship. But on the Akello side, it's the relationship with the health system. But to be honest, I haven't gotten to that stage yet.
I'm more than happy to jump in. I'll be talking a little bit later on the Mirah side, but as someone who has done a lot of these deals with health systems, almost certainly no, you will not be able to unilaterally use the software. You will have to go through legal approval to sign a business associates agreement, and that will be the way it's done. Usually there is a security assessment done by your organization's IT team that will vet the vendor and the software for security and privacy issues. And only after that's completed will the organization sign a business associates agreement.
Okay, thank you. I thought it was like too good to be true that we could just jump on board.
Yeah. Yeah, I think I'm one thing I'm kind of curious about is for smaller organizations. I'm working with a couple other startups. So for like early stage startups, since everyone is one, it's a lot easier. But with larger systems like yourself, I'm sure it's a lot more complex.
Great questions. We're gonna
There
move
was-
on. We're gonna have time at the end. Would you say, Monica?
I can hold it. I was going to ask another question that was from Kim, but I can hold it to the end.
Okay. So I don't want us to squeeze any of our speakers. So next, Suzy Hunter is here to talk about the AIMS caseload tracker.
Yeah, Tisha, did you want to share slides? You said you had a consolidated presentation, or if it's easier, I can.
I can do whatever works best for you. I've got them here.
Okay, why don't you go ahead, and that way,
Okay.
if others want to piggyback on that, you can just keep sharing. While they're coming up, I'll introduce myself. I'm Suzy Hunter. I'm the technical project manager at the University of Washington AIMS Center. I'm going to talk about the AIMS caseload tracker registry today. So on the next slide, I give an overview of what the registry system is.
Can everybody see? Okay.
I can. It looks good. So next slide. The AIMS caseload tracker is a web-based registry tool that we've specifically designed for behavioral health teams working in CoCM. We've really tried to simplify our system so that it's intuitive and it's easy to use, and really simplifies sharing of the most important information across the collaborative care team. In the registry, I'll show you some screenshots of what it looks like. Providers are going to track behavioral health contact dates, symptom scores, and also their systematic caseload review activities. And here at the AIMS Center, we've been developing registries since the early 2000s. So we've really designed this registry to adhere to the latest evidence base on effective collaborative care. And we're constantly looking at new research that's coming out about what the most important processes and what has the most effect on patient outcomes. And we've been doing this a long time. Our systems have been used in over 400 healthcare organizations, and I just recounted, we're in 35 states. Sorry, you can go to the next slide. Our population of focus is really around depression, anxiety, and PTSD symptoms in adults. Just last month, we've added some additional measures to track pediatric depression, anxiety, and ADHD symptoms. So we've recently added the SCARED, the Short Moods and Feelings questionnaire, and the Vanderbilt scales as well. All right, so the next series of slides are screenshots from our tool. We're going to look at the caseload list, which is your typical registry view. We're going to see some alerts and reminders that the behavioral health care manager receives. I'll talk a lot about the reports and statistics that we have available. And then we'll dive into what it looks like at the patient level, what documentation looks like for your team, and then a little bit about some quality metrics that we've developed so that you can see how your program is doing. And lastly, we'll talk about time tracking for billing purposes. Okay, I hope this is big enough for everyone to see. This is a view of the caseload list, which the behavioral health care manager would use to keep track of their current list of patients. And I really like to point out that the behavioral health care manager curates the patients that are included on this list, meaning we are not using any sort of automatic inclusion rules that put patients on the list if they have depression symptoms. but rather the BHCM will enroll patients onto this list when patients engage into the collaborative care program, and they can deactivate patients when they complete an episode of care for any reason. The list is also, sorry, we're going to stay on here for another minute. The list is interactive, so you can sort by any of the columns to bring patients with highest symptoms to the top of the list, or patients who haven't been seen in a while to the top of the list. And there's also the ability to flag patients that you want to discuss during systematic caseload review. So it's really designed to help that collaboration between the BHCM and the psychiatric consultant as they're determining who they'll be discussing each week during that caseload review. I know there's a lot of abbreviations on this screen, but really just to summarize what you're looking at is a list of patients. So each row represents one of your patients. You can see what is their current treatment status. Are they newly enrolled? Are they in active treatment? Are they on a relapse prevention plan? And then you're looking at symptom scores. So the first score that's been entered in the current episode of care being the baseline score from which we're measuring improvement. And we're showing that right alongside the most recent score. We're color coding those scores based on evidence-based cut points or published cut points for each of the scales. And then in the middle, all of those dates are showing dates of contact. So first and most recent care manager contact, the most recent psychiatric case review, and whether the patient's on a relapse prevention plan. We're also able to summarize a patient's episode of care, looking at how many sessions they've had, how long they've been in treatment, and even how many minutes each patient has had this month. So if you're getting to the end of the month and maybe you're trying to reach a billing threshold, you can really easily see who you might want to get in. Okay, next slide. I'm going to try to keep moving here. The reminders page is actually the first patient that care managers see when they log into the registry. And it's just intended to show who needs some sort of attention from them. So who is overdue for their initial assessment or their follow-up appointment. We have logic in the registry that's going to remind you to see the patient every 2 weeks throughout the course of active treatment, which would then decrease to less frequent visits when patients are in relapse prevention plan status. Next slide. All right, so once we have all this information, there's a lot of different ways that we can slice and dice the numbers to show you how your program is doing. What you're looking at here is just an example of a report that lets you look across your whole entire health system. You can see how each care manager is doing. You can look at it by clinic location, by primary care provider, and you can see all sorts of numbers like caseload sizes, frequency of appointments, and average remission and response rates for each patient. I won't go into a lot of detail. Let's keep moving. All right, so here we're going to dive into the patient level. Once you click into a patient's name, you're opening up this summary of the patient's current episode of care. So that first table is showing a list of every single contact, behavioral health contact that the patient has had during this episode. And then we're graphing the symptom scores below. So if it looks like this patient was tracked with both the PHQ-9 and the GAD-7 scales, and you can see that graphed. On the next slide, I think we're going to look at how that information gets entered. So we're very aware that the AIMS Caseload Tracker is a standalone tool that's used alongside your electronic health record. We understand that it's very important that we streamline the system so that the behavioral health care manager is not required to double document a lot of information in 2 places. So at every patient visit, what you're looking at is an example of what would be documented in the registry. You can see that they're putting in the date that the contact occurred. They're entering any symptom scale scores that were collected. They can either answer individual answers and the total score will be automatically calculated, or they can simply enter the total score at the top. At the bottom, we're collecting the location of the session and how many minutes it took. So the idea is that it would only take a few seconds to document the contact in the registry. The payback being all of the caseload management tools and the prioritization tools that we've been looking at previously. We have also developed a set of quality metrics that are kind of the most important process measures and outcome measures that give you visibility into how your CoCM program is doing. Those measures that we have come up with are listed here. Caseload reach is a measure of how many new patients you're able to enroll onto your caseload every month. So it's kind of a measure of healthy caseload turnover. Are patients completing their episodes of care to make space for new patients to come onto the caseload? The second measure is the engagement measure, where we're looking for at least one contact with each patient per month. So we want to make sure that patients stay engaged. Measures completion is really underscoring the concept of measurement-based treatment to target. So are you completing at least one scale at each of your contacts? It's showing a percentage of the contacts that were completed during the month that had a scale entered. Depression response is really based on the standard definition of 50% improvement on your PHQ-9 scores. What proportion of your patients have met that benchmark after a certain length in treatment? For anxiety improvement, it's looking for a 5-point improvement on the GAD-7. PTSD improvement is looking for, I believe it's a 10-point improvement on the PCL-5. And then the psychiatric case review measure complements those other kind of outcome measures. So any patient that is not meeting those response or improvement criteria, have they at least had a psychiatric case review completed during the month? So for patients not improving, that would be something that would be measured in that last metric. Next slide. I think for time tracking, I'll just mention that the registry is collecting minutes for behavioral health care manager contacts, as well as care team collaboration activities and case review activities. And once those are collected, we can total those minutes up per month and produce a report that shows minutes per patient per month to assist with time tracking for billing. I think that's all I wanted to say about that. What's on the next slide? Pricing. So we're a not-for-profit academic research institution, and our mission is really to make collaborative care possible and done well at as many sites as possible. So you can see that our prices are published clearly on our website. It's an annual fee that's based on the number of users who would actually be logging into the registry directly. That would typically be your BHCM, your psychiatric consultant, and perhaps your behavioral health program supervisors as well. And to make this doable for as many organizations as possible, we also offer discounted pricing for nonprofit safety net organizations. Those are the prices listed below. Okay, next slide. Thanks. I did want to mention that the AIMS Center does also provide technical training and, we also provide clinical coaching and implementation support services in addition to the registry. So we have a really great team of folks at the AIMS Center who can offer that. We have a work group that meets to kind of vet requests and change requests that are coming in to make sure that our registries are always up to date based on the latest evidence around effective practice. And we do try to make ourselves available to hear feedback from our users, and we're often taking suggestions based on what folks tell us will work better for them. What's on the next slide? No, I'm getting near the end. There we go. All right. On the last slide, I've just linked to where you can find more information about the AIMS Caseload Tracker. Our prices are published there. We have a 10-minute demo video where we walk you through the tool so you can see what it looks and acts like as you're using it. So please don't be shy. Reach out to us at the email address listed if you have any questions, and my team will be happy to answer. Thank you.
Thank you. For the sake of time, we're going to hold these questions to the end, so that we can make sure we get through everybody and have some time to chat. Thank you so much, Suzy. All right. Next, we have Ben Hillyard, who's going to talk to us about, is it Mirah?
It's Mirah.
I've only seen it. Mirah, okay. And do you want to do your own slides, or do you want?
Yeah, my co-presenter, Hugh, is going to put the slides up in a second. So I just have a quick introduction. So my name is Ben Hillyard. I'm a licensed clinical and mental health counselor, and I am the VP of clinical implementation at Mirah. So very, very excited to co-present a quick overview of this Mirah registry. And I've asked Hugh Barrington to join me. Hugh is the Chief Technology Officer and also co-founder of Mirah. In addition, Jessica Lyons is also from Mirah, is also here too. So I know I only have 10 minutes, but it's important to give some context. Hugh, Jessica, and I have spent countless hours together, sometimes well into the evening, presenting, building our registry. It's kind of a lesson of love, and really worked on it a lot. Hugh has another title, and he probably hasn't heard this yet, but he also is the chief translator of between our clinical teams and our engineering teams. It's not a very fancy title, but it's super incredible. So the Mirah registry has been built from a provider perspective from the very beginning, but it also has expanded upon a 9+ years of being in the measurement-based care space. So I'm glad Hugh's going to take over and I'll give you an overview of our product.
Thanks, Ben Fincho. Yes, as Ben said a little about Mirah, we've been providing measurement-based care services in specialty behavioral health for some years now, and somewhere in the middle of that journey, we were fortunate enough to be introduced to Ben and to Jess, who helped convince us they wanted to use our measurement-based care product to start their collaborative care implementations, and they managed to convince us somehow that integrated care, and particularly collaborative care, was going to be the future of mental health, and that's why we partnered with them to make an entire registry that complements our measurement-based care product. Since then, we've added an entire distinct time tracking facilities to the registry product, and talk about that. And we're in use everything from small independent PCP offices to large healthcare systems for collaborative care now. We're used both by providers who are hiring, like primary care providers who are hiring their own staff, but also we're used by behavioral health organizations who are staffing into collaborative care programs and using our software as the basis for what they do. And as part of that, going back to what I was saying earlier, we've done a lot of EMR integrations to get kind of into Epic and all of those things. So more than happy to talk about that too. I'd say our unique perspective is informed by our history as a measurement-based care company. And that's that we believe that collaborative care is measurement-based care, that the better the quality of your measurement, the better quality of your collaborative care. And we've spent a number of years doing measurement-based care, and that's the insight and the specialty we bring to the collaborative care field, we hope. And that's why we have 450 measures in our measurement-based care library, and a substantial percentage of those are used for collaborative care in one way or another. Obviously, you're starting with PHQ-9, GAD-7, the basics here, but as you move into more specialty diagnoses outside of depression, anxiety, and going into different patient populations, has measures for measurement-based care down all the way to infancy. And obviously, there are kind of constraints on where you're implementing your collaborative care, but it's not going to be stopped by the measures that you're using. You have to, especially on the adolescent and pediatric side, make sure you're measuring the right people. So getting the caregiver responses, we have support things like the teachers for the Vanderbilt, and doing that seamlessly in a way that engages everyone in care is an essential part of making sure that the care managers have the data they need to do an effective intervention. So rather than kind of going to a demo or anything like that, I instead wanted the time to just kind of walk through some of the insights we've got, and that hopefully aren't too obvious to people, and how that's influenced the way that we've built the product out. So the first one I'd just like to talk a little bit is that idea of what you're measuring and how multidimensional scale measurement can be so much more than just tracking to a symptom and targeting a particular symptom. How that those secondary dimensions for care can be so important, and how by using things like broad spectrum global functioning measures, you can keep track that the dimension that you're measuring is in fact the dimension you should be measuring, that you don't end up with someone diagnosed with depression who isn't actually really suffering from depression and you're not seeing any motion on the PHQ-9. If you were instead looking at a different scale, you could be seeing further treatment. And so that's where, once again, our basis in measurement-based care has proven a real advantage. We generally, for example, recommend that although you should be targeting a measure like PHQ-9 for progress, especially in cases such as adolescence, it's really useful to be able to measure those secondary dimensions. So, for example, a caregiver strain measure, you're treating the family unit, so let's measure the family unit and see what's working and what's not, and see if there are other things. Measurement-based care is not just about the score, it's about the individual item responses and using that to drive specific interventions, and how getting those secondary dimensions for care can actually drive better care for the patient. The second thing when it comes to is things like additional diagnoses or other things you should be measuring, and our platform lets you measure whatever you want in terms of the assessment bundles you've set up, and then compress those, talking about the technology side, into something that can be used for immediate action. So we'll see here, if we just look at the standard measures, on the left here, we've got a status badge, which is showing in a very short space of a very short amount of space, any self-harm risks on the left is the leftmost icon, a targeted treatment, whatever you're selecting, PHQ-9, GAD-7, and then finally, any multidimensional broad spectrum global severity scales. And this allows you to do things like immediately spot patients who are globally severe while still showing, for example, a mild on the PHQ-9 as something that maybe a different intervention is required. And so we've kind of taken those learnings and built those into the product. The second thing, there we go. Second thing to talk about is time and task tracking. So a lot of people doing collaborative care are doing it even with sticky notes or a notebook, keeping track of where they've spent the time. And I know some people do it in Epic, but it's kind of also a very frustrating experience often to track the minutes that you're spending in Epic moment by moment. And so in theory, this is something that technology should be able to help with. You're talking about, it's not a great experience to have to go at the end of the day and track all your minutes kind of field by field, or you're going to forget minutes and they're not going to be billable, and that's going to undercut the financial health of the program. And so we started off with, this is obviously something technology should solve. How can we do it? And so we built a system and we deployed it. And when we talked to our customers about it, it turned out that a fair few of them were in fact not using the system we designed at all. They still had an Excel spreadsheet or something that they were writing the times in, because what we found is that whenever you design a software product, the choices you make in the design nudge the people, care managers in this case, towards certain ways of working. And if that doesn't closely enough interact with what they want to do, they're not going to use your system. And so we had to actually go back to the drawing board in a lot of our task work to make sure it was meeting the needs of our users by allowing them to do what they wanted, which in our particular case was being able to drag and drop the priority of tasks, to be able to keep track of what they should be doing with each patient and be able to add that task in and say that's important or that's not important, or I want to do this now, or I want to do it in a certain context, or that can wait till next week. So by allowing the technology to actually represent what the care managers, actually how their care manager's job runs day to day, we saw that go away. And now we're seeing fewer people use a spreadsheet to keep track of the time tracking. The next thing, just the final kind of little anecdote I wanted to talk about, was case consultation. And so we started off talking about the time and task tracking with, you do need to keep track of the time for case consultations. But we started with just a simple task saying, you should consult, you should do the case consultation, please. And what we found was that workflow wasn't driving sufficient value for the meeting to be effective, both in terms of which cases you're discussing and also what you are discussing, the format of discussing these cases. A lot of our customers are starting from scratch as organizations who don't have a lot of background in collaborative care and don't really know what an effective way of doing case consultations is and how that's going to work and who to talk about and how to talk about it. So this is once again where technology can help a little bit, because we focused on building a workflow which brings case consultation to have a set of sensible defaults. So when you're constructing the case consultation, there's a load of buttons which suggest things like, and unfortunately we don't have screenshots for, I think, in this deck, case consultation notes saying, what are we going to talk about? Or is there a med change here? Just like those nudges to provide a sensible default to make sure the meeting runs to task and on time. I've got, what, 2 minutes left, I think. The final thing I just wanted to touch on is our kind of overall thesis here, which is technology can get you so far, especially on the caseloads, but it requires a whole lot more to get it to work entirely. It's more than twice as difficult to have 60 patients than 30 patients on your caseload. There's more coordination, there's less time, there's more just difficulties going on. And it's certainly more difficult than 50% more difficult to have 90 patients than 60 patients. As the caseload size starts going up, all the little tricks that you can usually do, unique initials for names are not necessarily guaranteed anymore as the caseload grows. You haven't got enough time. You can't keep all the context for each patient just in your head. You need help to do that. So in order to make these programs sustainable at a financial level, to see those higher caseloads so that a program can actually be financially sustainable over the long run, we've had to invest quite a lot in the technology to help people keep more information, not necessarily in their head, but at their fingertips at any given time. And that's where things like the status badges we've seen, or being able to have a little avatar with the patient's initials to be able to track what you're doing when, or when you are looking at a patient, what are the single set of, the 3 things that you need to remember about this patient who you might not have thought about for several days? How does that all work together so that you can be effective as you need to when it comes? I think I'm over time now. Obviously, I'm talking fast. I've got a ton more I could say, but I just want to thank you all for the opportunity to speak. And if any of you are interested in talking more about this with me, obviously happy to talk.
Great information and some really good points generally out on registries and why it's so important, especially as we move, as we grow. The next person is Ashley, and she is from Hartford Medical Group. Ashley, hi. Do you going to share your slides or do you want me to?
Yeah, I can share my slides. Hi, everyone. All right, let me get this going.
While she's getting it going, I'm just going to say we have a very robust campground or camp, whatever the camp is. So I'd love for us to continue. Base camp. There we go. It's not a campground. I'm wanting to go camping. So I hope that we'll continue these conversations on base camp and in our future meetings too. So I'll let you take it away, Ashley.
All right. Hi, everyone. So I'm Ashley. I'm a licensed clinical social worker. I work for Hartford Healthcare in Connecticut within our medical group, specifically primary care. So I put together an overview of our collaborative care model registry that was built in Epic. Healthy Planet, so it's built in the Healthy Planet module, which is a population health module that helps us monitor, manage the health of our patients for our population. The way when we developed it, it was developed in a build environment, and certainly we followed the AIMS, the CoCM registry requirements guide, talk to our psychiatrists, what we really wanted to pull in and what would be most efficient for the behavioral health care managers in terms of utilizing it. We had an analyst team who helped us build, and I'm going to show you a couple aspects of it. One is our CoCM tab, which is where data is entered by the behavioral health care manager and then flows into our reports. So we have 5 reports we utilize. 2 we utilize the most, which are the first 2, our currently enrolled report and currently enrolled billing. So I'll keep moving. So I took some screenshots. So this is the currently enrolled report we have, and you can just see here up at the top, different data points we asked IT to build into the registry to automatically connect. I think, what really helps us is when our care managers are utilizing it is they enter specific follow-up dates when they know they need to follow up with patient, whether it's a medication check or whether it's the actual follow-up. Because for Hartford Healthcare, we are required to staff with our consulting psychiatrist a patient at least once a month. Certainly last consult contact date, and then it tracks the time per month, and I'll talk more about that. So this is just continued. You know, if you think of a screen going across from left to right, captures the minutes, billing codes, first PHQ9, recent PHQ9. I think visuals are helpful. So love the yellow. So the yellow indicates a patient's, you know, how they're improving or not improving in terms of change in, you know, PHQ9 and GAD7 from their baseline. So our patients who have had 50% reduction in symptoms, typically for concurrent 3 months, we move them towards graduation and create a relapse prevention plan, which I know we're probably all familiar with. You can see here. And once they graduate or when they become inactive because we refer them out to specialty mental health, the CoCM resolved, that data gets entered there as well. And just again, what I really like about this report too is it does list the current behavioral health meds, current behavioral health problems, because we also utilize those, you know, when it's billing day. And I'll show you about linking the diagnosis to the encounter. And you can see right here, just data for us, you know, insurance, CoCM follow-up notes. Oftentimes our care managers can write, you know, typical things about like, you know, started Zoloft XYZ, need to increase XYZ. And so they use this report regularly. So hopefully this is helpful. So this is our billing report. So this is the other one, the one we use, you know, at the end of the month. What I like about this is, you know, as Hugh was saying, it is cumbersome to go back in the in the open encounter or addendum encounter and add in the minutes into the tab, which I'll show a visual of. But you know, this is helpful that it shows this because we can compare and contrast, making sure, you know, technology isn't everything, making sure that the minutes match the billing code. And it auto generates based on the minutes and based on if it's the initial month or the subsequent month, which codes are going to pop up here. I'll keep going. So this is our tab. So if our behavioral health care manager, you know, is giving a patient a call to see if they're interested in the program, our tab has a couple features. First is the enrollment aspect. You can click yes or no. If you click yes, this is what comes up. So upon intake, this is where they, you know, enter all of these data points. Enrolling provider is always the primary care provider because we bill into them, of course. And then you can see here in these open encounters, this is where they can enter time. So when we're on consult with a psychiatrist, you know, we're tracking the time and they actually enter the psych consult minutes before they sign the note, which is really helpful. Okay. So this, again, you know, just a closer up visual. Usually we use specific follow-up dates, you know, depending on, you know, work schedules for patients, et cetera. But of course, you know, if it's someone who hasn't been answering the phone, we can make a note to just give 2 weeks to make sure we're trying to call them again, or maybe send a MyChart message. So it's another form of contact. So the charges section, and this time tracking here is the same as this. So our CoCM charges, so this is on billing day in the currently enrolled billing report. Here you would search for a new charge. So you click add. This is what comes up. So, you know, you utilize the billing report when it generates the code so you know which one to click. You always cross-check. You can see here just an example. We have to link the visit or link, yeah, the encounter to the diagnosis, of course. You can see here, under here, we always put in the department where the PCP is, and the PCP is the provider. We have, you know, this, you know, if there's multiple codes of, if it's not the initial month or if it is the initial month and you go over minutes and it generates another code, it'll show you right here. And so if I had 2 codes, the other would populate here and you would do the same thing, click into it and make changes that are appropriate. So when this was originally built, we had an IT analyst who was fabulous. He is now a freelancer. And he was really wonderful to work with. So I wanted to make sure I included his contact information. But I know someone I saw before I shared my screen, someone in the chat was asking about Epic. We really love our registry and find it very useful. So always happy to talk with folks. I can put my email in the chat. Yeah, appreciate your time and thanks for inviting me.
Thanks so much. We have left a little bit of time. Yay.
Can you believe it? So I want to thank those who have spoken and presented today. As Tisha mentioned at the top of the hour, there's a lot of things going on out there regarding registries and a lot of services that people are providing to those who are trying to start up collaborative care or just do a better job at service delivery of collaborative care. So we have other individuals that will be highlighted. I do ask that the presenters today, if you can email me your presentations and I'll upload those into Basecamp. I would rather it have your logo and all of those things on it. So if you would send that to me, it could be in PDF format, whatever makes the most sense for your organization. So if you'll send me that and your email addresses, then I'll make sure that that's posted on Basecamp. We do have some questions that were asked in the chat. Most were answered, but there were a few that weren't. So I'll start with those. There was a question from Jen Thomas. Anyone using any outcome measures in their collaborative care registries, such as the outcome rating scale?
I'll add on the Mirah side, we have 450 different measures in the library, so we have a wide variety of things. I don't know if the ORS is one of them. Were you intentionally differentiating between outcomes and kind of a measurement-based care progress measure in that question, or just looking for more general measurement?
Yeah, it would be a neat application of a registry to have some outcome data alongside the PHQ-9 and GAD-7. I feel like that's something it's hard for us to quantify in clinical work.
So, oh, sorry, go ahead.
No, go ahead.
No, I had a question about this earlier in one of the conversations. I think, yeah, sorry, I guess there's a way, we can definitely have a whole large set of databases of measures. The way I've been approaching this is like, just make it easy for anyone to create whatever measurements that you want, and it's just put that into the system. So if it's not, I don't know how you guys do it there at Mirah, but the way I'm kind of initially approaching it is that you have a measure. Naftali shared some measurements that he uses, and I think some of them were outcome based. And the concern I had with just throwing it into Akello was I had no idea how to run these measures. So just by being able to provide that, I paused. I kind of stepped away from sending out measurements because I was concerned of what the safety or risk is of who's running those measures, and let the clinician just define what measures that they want. That's what I was doing. I don't know if that's right or wrong.
So our background in the measurement-based care, we've been sending out text messages for completion for assessments for years. So that's primarily the way that our assessment data gets in, is that that a patient automatically gets a text message at the right with the right bundle at the right time, just set up on a cadence. And so the real problem with all the different measures is, because behavioral health has been previously kind of undercoded in a sense, that a lot of these behavioral health assessments beyond the PHQ-9 and GAD-7 don't have a standardized representation across multiple systems. And so when it comes to low-ink codes, et cetera, a lot of these scales don't have them. The danger of building a custom one every time is that when it comes to using the data for external reporting, so for example, going and talking to an insurer to prove the value of your care, et cetera, then without that standardization, everyone's talking off a different hymn sheet, and it becomes a problem to actually get a routine outcomes monitoring base, which can then be used for population level tracking. So there's a balancing factor in
unless you know the codes. If you know the codes, then you can standardize it. But if you're just randomly putting stuff in, yeah, you're gonna have that
issue. And very few behavioral health assessments have standardized codes.
That's interesting. That PHQ-9 is standardized, right? But
PHQ-9 and GAD-7 have low ink codes, which are standardized. Almost no other behavioral health measures do.
That's interesting. Okay.
Yeah, that's great. Thanks for the answer. That piece of functionality, that's the hard piece to capture as a clinician, right? Is someone improving with their depression, anxiety? PHQ GAD-7 gives us good data, but it's harder to quantify some of what does that mean to you? What's your functioning like? Are you back to work? Are you avoiding the ER? Those types of things. It would be great.
A lot of our customers use, for example, just the HUDAS-5 as a kind of general functioning measure that they're also monitoring as their kind of more broad spectrum thing. So there's plenty of options there.
So my initial use case that I'm working with one of the customers is that they're trying to generate a PHQ-9 based off of your medical history. So you look at all the medical records, you're running kind of like data processing, and then based off of that, can you make some sort of assessment? But in that sense, it's like it's fully customized and not a standard at all. It's a tough problem.
So that was all the questions that were not already answered in the chat. We do have 3 minutes, but I also recognize people need to transition and bio breaks and all of those things. But were there any other questions that anyone might have had?
I actually have a question because I know there was a little conversation around Epic integration and I think for Ames or Suzy, you mentioned that you guys their integration costs really kind of impacted your integration, which is unfortunate. And I'm kind of seeing that too. Yeah, I guess I don't have a question, but I wish we can talk more about that.
I can share a little bit more about our experience with EHR integration. We were able to successfully integrate with several EHRs, including Athena, NextGen, and Cerner. We were doing a one direction integration. So we were pulling visit dates and scale scores from the EHR in order to display them in the registry without double documentation. And the technology is there and it was solid and we had it working in several healthcare organizations. But what we found was that the integration fees that were imposed by the EHR vendors were so high, they were multiple times bigger than the cost of our software. And a lot of large health systems who have the capacity to build a registry into their EHR, that's clearly the ideal solution. But for medium and small size organizations who don't have those resources internally, that's really where the Ames caseload tracker is, our value lies there. And those sites couldn't pay those fees. So we ended up discontinuing that product.
Just to follow up on that, like, do you see that a lot of people that are starting CoCM are comfortable with that? They don't need the EHR integration, but you can kind of live off of this different system just to do integrated care and then maybe figure it out later down the road?
Yeah, absolutely. We find a lot of sites will start using the Ames caseload tracker when they're starting their program. They'll use it for a few years while they figure out what they need. And some sites eventually phase off the Ames caseload tracker when they build their own registries. And that's a great success for them. We don't see that as a loss, rather it's a gain because the site is more efficient. So it's I think the Ames caseload tracker is a great way for sites to kind of bridge that time period where they're figuring out what their needs are and how their team is going to use the system before they start their own build, which can be a really big investment.
Integration fees have been going down for the last few years. 5 years ago, well, 10 years ago, they wouldn't let you. 5 years ago, it was extortionate, and now it is merely expensive. And so the trend is positive.
I think Athena might be the exception because they just implemented fees on their API for the first time in 2023.
Yeah.
So they're raising their prices.
Thank you, everyone. I wish we had 2 more hours. Because this is awesome. Like we said, please join and ask questions and continue the conversation on Basecamp. We're gonna have the slides available. Contact information is available. I mean, this was really something we wanted to do just to get the word out there, everybody kind of learn about options and keep asking. So thank you so much. I think this was just incredible. So appreciate it.
Suzy, Ashley, Ben, Hugh, I'm missing someone, Jessica. I dropped my email address in the chat. So if you could send me the PDF of your slides, that would be amazing.
Thank you very much.
Thank you all.
Will do. Thank you.